Today's guest is Dr. Stuart Fischbein, also known as Dr. Stu to many. He's a board-certified OB-GYN, international speaker, educator, and longtime advocate for informed consent in physiological birth. After training in the traditional medical model at Cedars-Sinai Medical Center and practicing obstetrics for decades, Dr. Stu began collaborating closely with midwives and supporting women seeking out-of-hospital birth options. Over time, that experience transformed the way he viewed maternity care, autonomy in childbirth, and the importance of individualized, evidence-based decision-making. He is a co-host of Birthing Instincts podcast alongside midwife Bliss Young and has become widely known for his work supporting VBAC, breech, twin, and home birth conversations in a respectful and deeply nuanced way. Dr. Stu has lectured internationally on childbirth, informed consent, and collaborative maternity care. And today, we are diving into some of the most important conversations surrounding modern pregnancy and birth, from Group B strep and home birth transfer statistics to fetal monitoring, MTHFR, PCOS, endometriosis, and more. Dr. Stu, welcome to the Holistically Well podcast.
Thank you, Kayla. Thanks for having me. It's always an honor for me to come on and speak to an audience that I might not otherwise reach. So again, thank you for this opportunity. I'm looking forward to talking with you.
Awesome. Well, today's conversation is going to be nuanced. This is, of course, not specific medical information or medical diagnoses for you. This is not to be fear-based or blindly atavistic, but rooted in informed decision-making, physiological birth, and what truly keeps mothers and babies safe, maybe in a way that you didn't necessarily know beforehand. So let's dive right in. Dr. Stu, what do you wish more women understood about Group B strep, colonization versus infection?
Yeah, so you're getting right to it. I want people to understand that I was a traditionally trained OB-GYN. I came out very medically oriented and thinking like most of my OB colleagues still do to this day, kind of stuck in a hamster wheel. And the only reason that I've evolved to where I am today is because I had the good fortune of being approached by some midwives early in my career and asked if I would take their home birth transports. In California, we tried to have collaborative relationships. It's very difficult. Many states require physician supervision, and yet doctors aren't willing to supervise midwives, and so it leaves women with fewer and fewer choices. But being approached by these midwives and saying yes, not because I thought home birth was a good idea, but because it was a way for me to generate revenue. And early in my career, practices were different in those days. And I was not an employee of anybody. I didn't get a salary, work a shift, do like most doctors are now, which I think is one of the worst things that ever happened to doctor-patient relationship, is for doctors to become compromised in their ethics by being employed by somebody but being responsible for a woman's life. And these midwives started to begin to ask me questions about, why am I doing certain things? Why do I wear a hazmat suit when I deliver a baby? Why is a woman sitting with her legs up in stirrups? Why am I cutting the cord right away? Why does the baby go directly to the warmer? And I really didn't have an answer for them. I had the answer that everybody always gives, which is, well, that's our protocol, which doesn't necessarily mean anything. Right. So the same thing, this will apply to pretty much every answer that I give today, is that my interpretation of the data has evolved significantly from what I was taught. And most doctors and maternal fetal medicine specialists, once they come out of residency or fellowship and they know what they know, they rarely learn anything new. There's an old Dalai Lama quote that says, if you speak, you only hear what you know, but if you listen, you might learn something new. And my colleagues don't tend to want to learn anything new. They're very comfortable in that. So Group B strep is something that is, like a lot of things in our medicalized obstetric world, used or often discussed in a fear-based way, as if it's extremely dangerous. And I don't want to downplay it, because Group B strep is a bacteria that is a normal colonizer of most men and women. Not most, but a good percentage. So it would be considered normal flora in you or I. It's not a pathogen in you or I. But on rare occasions, babies who pass through or have either an ascending infection can catch this bacteria and get what's called early onset Group B strep disease, which is can be a very terrible thing that happens to babies. And so the question is what to do about this normal bacteria Because even if you treat this bacteria, say you find it in a woman's urine at 10 weeks pregnant, and you give her an antibiotic for that, it's very likely that you check her again in 10 weeks or 5 weeks and it's going to be back again because it's in her environment. It's in her partner's environment. You cannot eradicate it. It's a transient bacteria that comes and goes. And the culture doesn't necessarily tell you what is going to happen. Yet, in the medical model, which tends to always err on the side of caution, which is a kind of funny way of saying something because it actually means making a mistake to be cautious. They will always err on doing more interventions. They talk about giving antibiotics for GBS, and I know this is a long-winded answer, but this is sort of important to lay this background information. So they tend to give antibiotics when a woman is colonized with this bacteria, but that assumes that antibiotics have no downside. And when you discuss this with most OBs, they will tell you that it's much safer to give antibiotics to all women who are colonized with GBS than it is to not give it. But they never discuss the downsides of antibiotics and how it affects not only the mother's microbiome, but the baby's microbiome. And most of our immune system is based in our gut when we're born, and it's based on the first bacteria that we're colonized with. And those bacteria should be mom's vaginal and skin flora. When you give antibiotics, you alter that, especially if you give enough antibiotics where you've been doing it for 12 hours or 16 hours of labor and they've gotten 4 doses of penicillin. You are going to change that, and you are going to increase the downsides. These risks are never discussed. So any woman who has this, whose doctor is recommending antibiotics, should approach their doctor and say, what are the downsides of antibiotics? And if the doctor just blows it off, that's sort of a red flag, but you'll have to do the homework yourself then. So what does the American doctor do? The American doctor generally will culture a woman at around 36 weeks for group B strep. And if it's positive, you'll be labeled as GBS positive, and you'll be told you need antibiotics when you're in labor. The rest of the world doesn't do that. The rest of the world has pretty much given up routine screening for GBS, and they treat symptomatically. And this makes much more sense to me.
Sure. Because
you can't tell which baby's going to get it and which babies aren't going to get it. And the incidence of group B strep's infection in a baby in women who are colonized who don't get antibiotics is only about 1 in 200. So even in women who are colonized with GBS who don't get antibiotics, 99.5% of those babies will not be affected. But the medical model says, well, we should give 200 babies antibiotics to prevent one case. And that's one way of thinking.
Sure.
But again, that's thinking that there's no downside to giving antibiotics to 199 babies who don't need it. And that's not the way that midwives think. It's not the way that I've learned to think. I think, more broader, I think what's nature's design. So some of the risk factors that would imply that maybe antibiotics should be given in that scenario, if you know you're GBS positive, are if you develop a fever while you're in labor, if you have prolonged rupture of membranes, like over 18, 24 hours, if your baby is premature, or if your baby's heart rate pattern begins to change and you start to see what's called the fetal tachycardia, which is where the heart rate baseline starts to rise. Those would be indications that maybe something more unusual is going on, and antibiotics might tip the scales toward using them as opposed to just generally, shotgunning every woman with it. And that is the way most European countries deal with GBS. They treat symptomatically.
Mm-hmm.
If you rupture your membranes at 32 weeks, they're probably going to want to give you antibiotics. If you have a fever in labor, they're going to want to give you antibiotics. But they're not going to routinely culture you and then label you as GBS positive because they know that most GBS positive women don't have a problem. So what to do with this scenario? You have to decide for yourself. You have to do your own homework. You have to discuss this with your physician. And I wouldn't wait till you're 36 weeks to discuss it. This is something you want to discuss with your gynecologist before you're pregnant, or even in the first couple visits of your pregnancy. How do you deal with GBS? What's your protocol? And find out and see if that's a match for your values.
Mm-hmm.
You should do that with everything with your pregnancy, but we're specifically now talking about GBS. So I think that that's pretty much what I would tell people, is that it can be a very serious infection when it happens. Its incidence is rare. It's quite rare if you give antibiotics. It changes from 1 in 200 to about 1 in 4,000. So antibiotics are 100% effective, but they're 99.9 something percent effective. Again, we just know that the microbiome has become much more prevalent in our discussions about our overall health, and destroying the microbiome, especially of a newborn baby, or altering it, will have downstream consequences. So it's not just it's not an easy decision to
Right.
just blanketly shoot every baby with GBS positivity with antibiotics. That's why using the symptom method that most countries are doing. I suspect that the United States continues to do it the same way it does because, quite frankly, I'm a cynic, and I think that it generates more revenue. Doing a culture generates revenue. Giving antibiotics to 200 people who 199 don't need it generates revenue. There's no revenue in not culturing and not giving antibiotics. You know, I used to feel bad about thinking my profession has this incentive, but it's so pervasive in pretty much every discussion that I have with people that I know that you can't get away from the idea that the goals of hospitals and medical systems is to generate revenue and make money. And they do that by doing stuff.
Right.
You know, it's funny, Kayla, if they had codes that said, we'll pay you for not doing something, then not doing something would become more popular.
Right.
It's basic economics. You know, you learn this in economics 101. You want more of something, you subsidize it. You want less, you tax it. So doctors don't see the downside of, by the way, this is a very important point. Doctors don't see the downside of giving antibiotics because their main goal is to get a healthy baby in the bassinet. And what happens to that baby at age 2 weeks or age 2 or age 8 doesn't concern them. If they've altered their microbiome and these babies now have more issues with it, and then they've confounded it by maybe giving toxins, injecting toxins into babies and causing inflammation and affecting their immune system that way and their blood-brain barrier, and that baby develops a problem 6 months from now or a year from now, that doctor's not going to know anything, and that doctor's not going to be sued for that. But if a baby comes out and gets group B strep and gets very sick or even dies, doctors are very, very fearful about their liability, and sadly, rightfully so, because we live in a litigious world. And so if the standard of care, even if the standard of care isn't necessarily correct, is to give antibiotics, any doctor who suggests you don't get antibiotics, like me, and leaves the decision up to the woman after giving them information. And I would say that most women that I give information to, once they hear both sides, they tend to choose not to take antibiotics.
Yeah.
Some choose not to even get cultured, and some choose to follow the European way of just waiting to see how my baby does in labor and then taking those cues and going from there.
Yeah.
So doctors are between a rock and a hard place, but it is a serious problem, but it is rare, and there is no perfect solution to it.
For the symptom-based way that European providers are more so leaning towards, are they waiting to screen for group B strep until a symptom is shown? Or do they first know, okay, this person is group B positive versus not, and we only intervene if symptoms occur?
They're not screening for it anymore.
Okay. But if a symptom arises, are they then screening
Yes.
for it within the
That's a good question. I don't know if prior to giving antibiotics, a woman develops a fever in labor, do they swab her vagina? I don't know. Because, by the way, that result, I mean, they have rapid strep tests. I'm not sure that they're always available in the socialized health systems of many of the European countries, but it wouldn't change anything anyway because they're going to give antibiotics. If a woman has a fever and GBS comes back negative, they're still going to give antibiotics. So I learned a long time ago from a laboratory professor. I could wish for the life of me I can remember his face, but I can't remember his name. He deserves to have his name remembered because he taught me that you should only order a lab value if the result is going to change your management. And we've gotten away from that.
Yeah.
You know, we run labs all the time, you know, on people for things like this. Well, we're going to give antibiotics anyway. Why are we doing a GBS culture? You know, and then somebody could say, well, if the baby gets really sick, we want to know what it might be sensitive to. And there are arguments to that, but that takes at least 48 hours to get your sensitivities back. And by then you're going to be treating the baby symptomatically.
Right,
not
right.
based on a lab test. I think that one of the failures of medicine is that it has become very algorithmic, and they fail to look directly at the individual patient, and they
Mhm.
treat the symptoms, not the patient. It's called the medical gaze. And they look at it and they see a woman, they don't see a woman with a fever, they see a fever. And the fever becomes the focus of attention, and the woman herself and her desires and her needs and her values are secondary, because that's how we're trained. And the system, again, because of the time limits, because of the financial incentives, because of the medical legal concerns, it's not likely to change quickly. Each woman that's listening to your podcast, when she's having her pregnancy, needs to fight for her autonomy and her personal sovereignty so that she can be involved in the decision-making process and not be put on that algorithm that's one-size-fits-all thing that so many doctors use these days, because it's just they feel for them it's safer. Not better,
Mhm.
safer.
Mhm. And Dr. Stu, can you speak to your years in medical practice and how many births you've attended? Because for me, you're like a household name, but for some of those listening, you're not. So, can you speak to that for a moment?
No. I can I can tell you that. Okay, I started my residency at Cedars-Sinai. I mean, at medical school, I probably assisted, 10, 15 births, in medical school, and it was a tragedy how those births went. I mean, most of them went well, but every single woman there got a medial lateral episiotomy. They were all in lithotomy position, whether it was their first baby, their third baby. So I was learning all the wrong things. But you know what's interesting? Doctors tend to not keep track. I don't know how many babies I delivered in residency. Um, and the terminology is such that, midwives use the term catch babies, or assist, not deliver, because the woman delivers the baby. But I tell you, at residency, a lot of times we delivered the baby. We did things we weren't supposed, that were not necessary. We put forceps on women that didn't need forceps. We did put hands on all breaches as opposed to doing upright vaginal breach, which we didn't know then. And that was normal. I mean, things do evolve, and things that we thought were normal then seem really kind of ridiculous now. I mean, they used to put leeches on people and bleed them and just drain their blood and to get rid of the bad humors, and that was thought to be good medicine a couple hundred years ago. And now we kind of laugh at that. I can tell you that people are going to look back at this era and say that you actually did what? You gave 6 vaccines to a 18-month-old baby at the same time? You did that? Really? You put mercury in baby's teething powder? That kind of thing. You encouraged bottle feeding over breastfeeding? These things are crazy. So I don't know how many I did in residency, and I didn't keep track as a hospital-based physician. Just didn't do it. I probably, I practiced in the hospital for 28 years. So even if I did 100 a year, what is that, 2,800?
Mhm.
I probably did more than 100 a year in some of my younger years because I covered other people and I was on call a lot. And then in my home birth world, I think I did 413 deliveries over 12 years. So that I kept track on because the midwives taught me to keep logbooks.
Right, right.
So I did that. So I'm sure it's 3,000, 4,000.
Yeah. Yeah. I just want to speak to your depth of experience here for those listening who are like, I don't know your background as well as myself and other providers
Well,
who
I am
might.
unique in that I'm one of the very few physicians in the country who spent 28 years working in the hospital and 12 and a half years working in the home. Very few doctors do that. And most of my medical colleagues, they're critical of home birthing. They've never been to one. They think they're experts in all things birthing, but they're not, because they've never been to a home birth. They
Mhm.
don't do breech delivery. That doesn't you're not an expert in all things birth if you don't see all things birth.
Yeah.
So I feel for my colleagues because that gives me an insight working in both worlds to see the difference between the two up close and personal. And that's why I think that what I have to say carries some gravitas, and it upsets the status quo. They're not happy.
Yeah.
Um, they aren't.
Mhm.
Right.
Which is exactly why I wanted to bring you on, because I started my career in the traditional hospital-based medical system as well, and then launched my own private practice. And I delivered my first 3 babies within the hospital system, and then my 4th baby, I did a home birth. So, I have learned a lot from you in terms of just looking at things from a different lens. And for those who are listening who or only seeing things one way or as a hospital-based approach way and think that something else like home birth is absolutely crazy or that low intervention is just irresponsible. You have so much experience to speak to through this, and that's exactly why I wanted to bring you on today.
Most of my colleagues have a lot of what's called cognitive dissonance. I mean, we all have it in some degree to as some aspect of our life. But one of the ways we handle cognitive dissonance, which is basically having thoughts that are in conflict with each other. That's what cognitive dissonance is. We'd like to have consonant cognition, which is where our thoughts are all in sync, but we don't. So one of the tools for dealing with dissonant cognitions to make them consonant is, as you said, is to kind of label people who deliver at home crazy, or to ignore the literature that says that low-risk women born at home have better outcomes in pretty much every category that you could possibly think of. They ignore those things, or they just say that that's crazy because that makes them feel better. We all do it. We all rationalize in some way in our lives why we don't join the gym, why we drink, drinks full of sugar. Well, we like them, and we find a way to make that fit with our life and justify it. When doctors look at the trail of outcomes that they've left over the last 50 years in my lifetime, all you can see is except for, there's been some advances in some very specialized areas, but for the most part, pretty much every measure of quality of care has gotten worse in the last 40 years to 50 years, despite all the interventions that have been created. I can just rattle them off real quickly if you'd like. I don't know if that's what you want me to do, but okay. So we look back to 1970, the C-section rate in the United States was 5%. The rate of cerebral palsy and the rate of interpartum death, stillbirth, has not changed.
Right.
It's gotten slightly worse, actually, but not changed significantly in 50 years. Yet, since 1970, the C-section rate has gone up to 35%, which is a 600% increase in the cesarean section rate, with no commensurate increase in outcomes. Induction in 1970 was rarely heard of. Now 30% of women are getting induced. Fetal monitoring came into play in the late 60s, early 70s. It was thought that it was going to prevent interpartum death and cerebral palsy. After 50 years of use, it's not shown any benefit whatsoever. And as a matter of fact, it's shown evidence of non-benefit, and it's probably the number one leading cause for the rise in cesarean section rate. We see things on the heart rate pattern that make doctors and nurses nervous. And so we decide we want to get that baby out, and we do a section, the baby comes out fine, and everybody pats themselves on the back and thinks we did a great job. But if you hadn't been monitoring that baby probably would have been fine anyway. Sure. Will they occasionally save some baby that they might have missed? Yes. But what are you doing to all the babies that you're intervening upon? What's happening with all these babies being born by cesarean section? What are you doing to their microbiome? What are you doing to the development of their neonatal reflexes because you didn't allow them to go through labor? The bonding with their mother, the delayed cord clamping, all that. You've altered all of that. Yeah. In the last 30 years, 20 years, we've seen NICU admissions double. If your system is so good, how come more babies are going to the NICU? Right. The system will their cognitive dissonance will say, well, that's because women are older, women are fatter, women are sicker. That doesn't account for a doubling of the NICU admission rate. There's no good answer for that. Either we're not doing well, or we're finding what more sinister is we're finding more reasons to put babies in the NICU because we can bill for that. And NICUs make a lot more money than labor and delivery and skin to skin with mom and baby. You can't. Actually, you can bill. You can now bill for skin to skin. So I don't know if you've ever talked about that on your podcast before.
No, I haven't, but
they do have a code now that the hospitals can charge you for holding your own baby.
That's insane.
It's insane. The coding thing is insane. We won't go there today. So that, that's where we are. And we're in a system that has not made things better. And yet these are the people that run the system. And it seems to me, maybe it's because my feeds me, wants to keep getting me agitated every morning. But it seems to me that most of the attention of the American College of OB-GYN and the Maternal Fetal Medicine Society and the state legislatures is on that 1% of those rascally midwives who are doing births at home, and not the 98% of babies that are being born in the hospital where the outcomes are the real problem.
Yeah.
I equate this to my time in California when they couldn't solve homelessness. What did they do? They banned plastic straws. So this is typically what administrative people do. They can't solve the bigger problems, so they go after the low-hanging fruit to make it look like they're doing something. And this assault on midwifery in many of the states that's going on right now
Yeah.
is not going to improve uh, health delivery to pregnant women. It's going to make it worse. It's going to force women to deliver freely or free birth.
Right. Right.
And that isn't safe. It's crazy, Kayla, because in many states, if a woman wants to birth at home, she can. But if someone licensed wants to come and help her, that's a crime.
Right.
If her grandmother or the taxi driver or the neighbor riding his bike by comes in and helps you, that's fine.
Right.
But you want to hire somebody who's
Trained and skilled and able to look at what physiological birth is and what normal labor and delivery is. And I think that's the biggest thing that I learned when I started looking into home birth for our fourth is this is not just a random person off the street coming to your house to assist you in your labor and delivery. They know what to watch for, signs of mom, signs of baby, that if baby is in distress or if mom is in distress, when a hospital transfer would be warranted and can do so in a non-emergent way the strong majority of the time. It's not free birth to what you're describing as not having another medical provider there or a skilled provider there to assist and to watch for what is normal versus what is not.
And by the way, getting back to the topic of GBS, if a
Mhm.
woman wants to have a home birth and has GBS and wants antibiotics, midwives can do that. Right. You don't need to be in the hospital to get your antibiotics. And I would tell you, by the way, this is my theory, but I've told you how the antibiotics can alter the microbiome. If you have a baby in the hospital and it alters the microbiome, that baby's going to be colonized by bacteria that's in the hospital. If you have your baby at home and you get antibiotics and you deliver in the water or you deliver on land, and the baby goes on your skin and your partner's skin and your little other kids come and touch the baby and the dog licks the baby, that baby's going to be colonized by the bacteria that are normal in your household. Those are much healthier bacteria. So giving antibiotics in the home is probably safer for mom and baby than giving antibiotics in the hospital. Do I have data that proves that? No, because no one's ever really studied it. But I tell you, a lot of things you don't need a study for to just prove common sense. Just makes sense that way. So GBS, even if you wanted to, if you could test positive, it's not a reason to have necessarily be forced into a hospital birth.
Okay, I appreciate you looping back on that. That's a great thing to know. Now, shifting topics to planned home birth transfers. So, when many people hear transfer, they often assume an emergency. Can you explain the difference between a timely non emergent transfer and a true emergency?
Yeah, most home birth transfers, and again, like I said, my own experience was that I backed midwives for 24 years, from 1986 until 2010, um, taking home birth transports, and also actually sometimes going to a home birth to maybe put a vacuum on or to repair a third or fourth degree tear, that sort of thing. So most transfers from home are simply for labor that has stalled out, or the discomfort for the woman has gotten so bad that she just throws in the towel and can't take it anymore. Those sorts of things, and so they're not emergent. And the decision usually comes with much consultation between the midwife and the birth team and the father and mother. And they make a decision. No, let's stick around for another hour. You're almost there. Let's see what happens. And they give her a pep talk, or she just says, no, I can't do it anymore. And they call me and they say, Stu, we'd like to transfer. We'd like to bring her in, or not just me, but anywhere. we'd like to bring her in. And ideally, you want to have a smooth transfer between home and hospital and a smooth transition. And of course, many institutions are not welcoming. And that's a sad thing because that's what they're there for. You know, I hear doctors complain that, well, we only get to the home birth disasters. And it's like, well, yeah, you're a hospital. If I have a
That's an
car accident,
emergency.
that's where I go.
Mhm.
You don't get the people that drove safely and got home. And you, so it's
Great
like, yes,
analogy.
that's what you get. That when you work at a hospital, you get, but that's not what most home birth transfers are. They're again for exhaustion, pain management, stalled labor, uh, or something that's not yet emergent, like a woman's blood pressure may be creeping up, or maybe the baby's heart rate is starting to hear some decels, or maybe the fetal heart baseline is rising, or something like that. Those are things that midwives are trained to listen for. And I always say this that because in nature's design, it's very rare for a sudden occurrence to happen that affects fetal status in such a dramatic way, like you hear in the hospital stories, which we'll talk about in a minute, because you're not messing with Mother Nature. You're not starving a woman, immobilizing a woman, interrupting a woman, hyperstimulating her, numbing her. You're not doing all those things that affect the mother-baby dyad as things go through labor. So you rarely see that rapid deterioration of fetal status that you can see sometimes in the hospital where they do what they call a crash C-section. And then they say, God, what would have happened if you'd been at home? Not really realizing, because they've never seen home birthing. They've only seen the car crashes, that
Mhm.
that this doesn't really happen at home with any kind of frequency like it happens in the hospital. So, and midwives are trained in that, and they usually can see it coming from hours away. And they may at some point take the dad aside and say, listen, if this pattern continues in the next hour and mom's not making enough progress, I think we should start talking about packing up and going to the hospital, just like we talked about in the office last week. So it's very calm. It's not usually, hysterical, running around crazy things that sometimes happens in the hospital where they push the button on the wall and people come running in and
Right.
everybody's, panicked. And if you're not panicked, then you clearly don't care. It's almost theater sometimes in the hospital when there's something that's bad that's happening, and if you're not panicking, it's almost like you're not virtue signaling enough. You don't really care.
Oh,
I've seen it so many times.
okay.
Why are we panicking? We're all moving panicking isn't going to make us move any faster. Let's just
Mhm.
move. Let's get her to the other room. Let's get her on the table. Let's do our thing. Um, so that's the case for most transfers. Now, there are some cases where there are emergent transports. And that is a potential problem where an outcome might have been better in the hospital if that woman had been in the hospital. But
Mhm.
you have to weigh that against the better outcomes that home birth has for all the women who don't need to be in the hospital.
Mhm.
So it's a weighing thing. And what are some of those things that can happen? You could have a membranes rupture and the cord could prolapse. And that could be a true emergency. You could have rarely something like an abruption of the placenta where the placenta begins to separate and mom's bleeding too much or bleeding too heavily. Now, most of those things are not necessarily emergent situations, but they certainly require a transfer and potentially emergent intervention.
Right.
And there are many other things you could have, but they're not common like they are in the hospital. I mean, when you take a similar cohort of low risk women in the hospital, the chance of a woman having a cesarean section starting labor at home is somewhere between 40 and 50% less than the same low risk woman starting labor in the hospital,
Right.
simply because of the model of care and the location and how they manage
Mhm.
um, labor. So there are those things, but there's also a false sense of security of being in the hospital sometimes because people think that when you have a cord prolapse in the hospital, that there's emergency help immediately available. And that isn't true in most hospitals.
Right.
Some hospitals, rare hospitals, have 24-hour anesthesia. They have in-house residents. So they can get a C-section started in 6, 7, 8, 9 minutes.
Mhm.
Which, by the way, if the baby's having a bradycardia, that's a really long time for that baby's heart rate to be down anyway.
Yeah.
Now, babies that are healthy, up until the moment that they're not, generally have between 8 and 14 minutes before they'll start to suffer irreversible hypoxic injury to the brain.
Wow.
So you have that. Like, now, most hospitals can't get a woman from the labor room onto a table, have an anesthesiologist available, a surgeon available, assistant surgeon available, a scrub nurse available in 12 minutes. Most hospitals can't do that. So even though you're in the hospital where you're more likely to have an emergency simply because they're managing you, you're not necessarily more likely to be safe because they can't do for you what they imply they can, which is do that emergency C-section that quickly.
Okay.
So it doesn't necessarily mean that you're going to have a better outcome with the same problem at home or in the hospital. People need to understand that. And again, I can't stress enough the pros of being at home for a normal labor are so obvious by looking at outcomes compared to being in the hospital for the same low risk pregnancy. And I don't even like the term low risk because defining risk doesn't really, that's a whole nother quagmire of what is low risk.
Yes, this is so true. And I think it's important for people to understand too, kind of the percentages of rates of transfer. So from my research is, 23 to 37% of first-time mothers and 4 to 9% of mothers who have had babies previously. So the number significantly drops whenever a woman has given birth, vaginally before, and this is a subsequent pregnancy in terms of the transfer rate. And of those transfers, as you mentioned, the strong majority are non-emergent.
And most will go on to deliver vaginally, by the way.
Yes.
Right.
And
And
they
those
just
your
need that
numbers are a
little bit
little
of help
higher.
along.
Your numbers are a little higher. I've seen numbers even higher than yours, but your numbers are a little higher than my experience in
Sure,
Southern
I'm sure.
California.
Mhm.
Our transfer rate for multiparous women was 2%, 1%, 2%.
Yes.
Multiparous is a woman that's had at least one vaginal delivery before. And for primips, it's somewhere around 10 to 20%, depending
Mhm.
on the midwifery practice. But yes, but again, most of the majority of those are non-emergent. And again, if you have a good transfer arrangement, and that's something that is important to find out if you're planning to have an out-of-hospital birth, what's the transfer arrangement? And if you have a lousy one in your community and you want a home birth, you may consider relocating for your home birth. I know that it's not easy to do, especially if you have dogs and kids and other things, but to go and get an Airbnb in another town and with a different team. But if you value your birth as much as you should, and you want the best birth experience possible, sometimes you have to pay out of pocket or have take on an expense that your insurance isn't going to cover. Don't
Mhm.
expect your insurance to want to give you a beautiful birth experience. That's not their goal. Right.
Right. Their goal is
Right.
making money. And I will say, just speaking back to those statistics, those were from ACOG. So it's not surprising that ACOG's values would be higher than your clinical practice numbers. And I will say from the home birth midwife group that I worked with locally, the transfer rate numbers were much lower as well. Very similar in line
Yeah,
with
I have
what
no
you
idea how
mentioned.
ACOG gets their statistics on that
Right.
because
Right.
ACOG is not keeping track of women who deliver successfully at home.
Hmm.
So
Correct.
how do
And
they
many
know
aren't
that
reporting it.
23% of them are getting transferred to the hospital? I mean,
Hmm.
there must be some lower level science, maybe the manostats, maybe some other thing where they found those numbers, but that doesn't make any sense to me at all. And it's certainly not for multips. Not again when they're properly chosen by a skilled midwife who knows what to watch for. Now, some of those women will be transferred antepartum,
Sure.
which means prior to labor, because they planned a home birth, but they develop preeclampsia, or they
Hmm.
develop honest, true growth restriction of their baby, or they
Okay.
develop some other problem that's outside the scope of a midwife, or
Hmm.
something that they're not comfortable with, or by regulation they're not allowed to deal with. I mean, some of the silliest things are like in California, um, babies born before 37 weeks or after 42 weeks are not allowed to be delivered with a midwife. So if you go into
Yeah.
labor at 36 weeks and 6 days, or you're 40, and so I see midwives fudging with dates, and I see midwives sometimes doing membrane sweeps and giving castrol at 41 weeks and 5 days, which is something they would never do normally, but they're doing it in order to comply with some silly regulation that decided that all babies at 42 weeks can't be delivered at home. These rules are not made by people who know birth.
Right.
They're made by people who are scared of birth.
Yes, and the due date can be off. So to speak to my most recent birth, my due date from how I calculated it, knowing my cycle length, would have been December 28th, but the due date from like the hospital-based system was December 25th because of the calculation that they use. So that's a 3-day difference. And so if you're being hard and fast on weeks and days, then that comes into play.
Yeah. Midwives unfortunately tend to fudge with the due date sometimes to give women a little bit more time at the end. But that means if she went into labor at 37 weeks, they might only have her at 36 and 2. And so now they're screwed on the other end. I mean, it's just silly things like that. And again, because the medical system works on algorithms. Nurses go to nursing school for a long time. Doctors go to medical school and residency for a long time. They're highly trained. Then they come out into the real world and they're not allowed to practice the way they want to practice. They're allowed to practice the way their employer or the way the regulations tell them to practice. So theoretically, why did you spend 10 years of your life, 12 years of your life getting a medical degree to come out only to be told by risk management lawyers and hospital administrators how you can practice and what you can and cannot do? Oh, we don't do VBACs at our hospital. Well, but VBAC is just a vaginal birth.
Right.
Well, we don't have the anesthesia availability. Well, then how do you do any labor at your hospital? Because almost all emergencies, C-sections have nothing to do with previous cesarean section. They have to do with cord prolapse or abruption or fetal stress or whatever, and you seem to handle those just fine. So doctors have to then skew their counseling to tell a woman that who wants a VBAC that, oh, VBAC is a little bit dangerous. We don't really support VBAC here, and try to funnel them down the path toward what the hospital wants instead of letting the doctor or the nurse or the midwife who've been trained all this training to use their training and individualize their care. It's not encouraging to me when ACOG says stuff because doctors will only follow the ACOG guidelines they like, and they'll ignore the other ones. But ACOG just came out with a guideline that says we should practice more like midwives, and we should have more continuity of care. They just actually said that.
Amazing.
But will that be adopted by the way the system works? Of course not. Of course it won't. So it's almost virtue signaling by ACOG.
Interesting.
They know that they're not. They're trying to look like they're actually doing something, but they're not enforcing it. It's got no teeth.
Okay.
Right. Because even they understand that the model of care that they've been doing is not working well.
Sure, absolutely. Yeah.
But it works well for those people that are running the system and controlling it monetarily and power-wise, and that's how it works. And that's the way of the world. And so we as individual families need to fight back and stand up for what we want. And just knowing that when you go to the hospital, that their policies are not laws.
Yeah.
And their policies do not apply to you if you don't want them to. You have the right to say, no, I don't think I want an IV. I'll take an IV if you can give me a good reason why I need it. But right now, my body's doing what it normally does, and I'm drinking and I'm feeling fine, and I don't want to have this thing in my arm the whole time. Well, what happens if you start bleeding and, we need to get some medicine in you right away? Well, then you'll start an IV just like you would any other person who came in through the emergency room.
So true.
Choking or a car accident or a gunshot wound. You'd figure it out.
Yeah.
I believe that the reason they start an IV in every single person is because they can bill for it.
Sure.
You know how I know that? Because during early COVID, when there was an IV shortage, they stopped giving IVs pre-epidural. It used to be standard practice that every woman that got an epidural got at least 1 liter or 2 liters of fluid prior to getting the epidural, because the epidural is known to cause a drop in your blood pressure, which can then affect your baby's heart rate pattern. So they would superhydrate them so that their blood pressure would drop less. When there was a COVID shortage, suddenly they stopped with the bolusing. So how important was the bolusing done in the first place?
Interesting.
Why is it back now?
Hmm.
Okay. Think about it for a second.
Yeah.
If it wasn't important when there was a shortage, then why is it important when there's not a shortage?
Yeah.
Yeah, these things just kind of get dismissed. But and again, I don't think that people that run healthcare systems have done a lot of common sense reasoning or logic courses when they were in high school, because so much of what's done is illogical. And all you have to do is look at outcomes to know that. If our outcomes are getting worse, a sane person would say, nope, we need to stop, figure out what we're doing wrong. If you're running a business and no one's coming to your sandwich shop, you don't continue to make the same sandwiches, or you go out of business. No, you come up with a new idea and you try to make a better sandwich. That's not what's happening in the hospital
Yeah.
setting. They have no competition.
So, shifting gears a little bit, a listener inquired about heart rate decelerations during non stress tests in late pregnancy. For reference, many hospital based midwife and OB-GYN groups require NSTs after one's due date to monitor baby more closely. Can you speak to why A, home birth practitioners do not require NST as a blanket measure for all women past their due date? And B, what women should do with this information if they're in a hospital based care system and are required to have one?
Well, let's first talk about the validity of doing testing on babies. When non-stressed and biophysical profile testing came in, it was started at 42 weeks. That was a random number, by the way. That's a ridiculous number. Why 42? It's just an even number. They picked it. Okay. And maybe it's because it's almost 2 standard deviations above what they considered to be the mean, but that's not necessarily the mean for all women and all primates. We tend to see that primates actually tend to go beyond 40 weeks. So, but they picked 42 weeks. And then they made it 41 weeks. And then they made it 40 weeks in 1 minute. And then they started at 39 weeks. And if you're over 35, they started at 38 or 37 weeks. And then if you are diabetic, they started at 32 weeks. Now, think about this for a second. If you're going to do all that, shouldn't you have evidence that it's actually improving outcomes? Nope. All right. It doesn't improve outcomes. What does it improve? Revenue generation. Reasons to go in to see the maternal fetal medicine specialist, to be scanned twice a week. No concern about what the scan is doing to your baby, about the non-ionizing radiation of turning on the scanner and putting on the colored flow Doppler and doing those things. No, they again want to err on the side of caution, and that always turns out to be more revenue generation. But it's not improving outcomes. So I would suggest that most women, unless they have a clinical reason, like their baby's measuring small, or they're feeling a change in the way the baby's movements, or they're not sure about the position, do not have a 3rd trimester routine scan. All right. There was a paper that once came out. I don't have the reference for you, so I'm just quoting from memory, that said if for women that have a scan for no reason in the 3rd trimester, they have a 22% higher risk of cesarean, simply because they had a scan where they find something that leads to more testing, which leads to more worry, which leads to an induction, which leads to that whole cascade of
Yeah.
interventions. So I wouldn't do routine. There should be no such thing as routine testing. Testing should have an indication. If you want to say post dates, fine. Then maybe 41 and a half, 42 weeks, you could start to do it. If everything else about the pregnancy is fine. If a woman has hypertension or diabetes, then you adjust that. You move it to where it's supposed to be, but you don't treat all women the same. And if a woman declines it, that's her right to do that. And she
Hmm.
should know, because the testing can be reassuring, but it also can find things that may or may not be worrisome, but will start the worry wagon going. And
Exactly.
then that leads to you being nervous and you be succumbing to the pressures of a doctor who wants to induce you. Why does a doctor want to induce you? Because it's convenient and because they know they'll get a live baby in the bassinet, and then their job is done.
Right.
And if they can schedule you to come in at 7 or 10 o'clock at night on a Tuesday and deliver by 5 on Wednesday, that's really good for them.
Hmm.
And we did that all the time. That was standard at Cedars. Cedars had booking times. We were very, very busy in induction hospital when I was there. And that was, I left Cedars in 2007. So it's been a long time since I was there, and they were doing it back then. And I think it's only gotten worse because the induction rates have continued to creep upward. As far
Totally.
as doing so I wouldn't do routine testing.
Right.
Uh, I I would do it if I trusted the doctors doing it to be able to interpret the data honestly,
Yes.
but I don't, and
Yeah.
that's sad for me to say. My colleagues are in a hamster wheel of their own making, and they don't have the courage to stand up and say to their bosses, inducing all women at 39 weeks is not a good plan,
Mhm.
despite what the ARRIVE trial said.
Mhm.
Or sectioning all breaches doesn't make sense.
Right.
80% of primate breaches can deliver vaginally.
Amazing.
97% of multip breaches deliver vaginally.
Mhm.
But yet 98% of breaches in the United States are delivered by cesarean section,
Mhm.
forcing many, many women to have unnecessary surgery, which not only affects them and that baby, but then affects all their future babies.
Correct.
But the concern of the hospital is to get the live baby in the bassinet. And if they get the baby in the bassinet by cesarean, they less liability, more revenue.
Mhm.
It's all backwards.
Yeah.
So this testing, now, if you see a decel, I think the question was, what if you see a decel on the testing? Depends about how the other testing looks and what the decel looks like.
Mhm. So, yeah, what should that mother do if they see a decel, she's in this situation, does she ask for follow-up testing to get better context?
Yeah. So, yeah, I'm sorry. I just when I get you need to interrupt me if get monologuing.
No worries.
I tend to do that. Um, so, yeah, it depends on what the decel looks like.
Mhm.
Is it a tiny little variable deceleration because the baby moved and grabbed its cord? By the way, those go on entire 9 months. If you monitored a baby for 24 hours at 24 weeks, you'd see there were decels. Would you do anything about them? No. But at term, we worry about them because, well, we got a baby that will do fine outside. Let's just get it out. But it depends what the other whole picture looks like. How's the fluid level? How's the baby's growth? If you do a full biophysical profile, you're looking at baby's tone and fetal breathing. You're looking at all those things. And if the NST is otherwise beautiful, the non-stress test, that's the heart rate tracing on the monitor with the belts. Um, if it looks fine and there's nice accelerations as baby's supposed to do, but there's occasionally a little decels, that probably is not significant. And you might tell the woman to do fetal kick counting, and you might tell her to come back in a couple of days and we'll just retest you. That seems a reasonable thing to do. Now, if you see decels on the monitor and the baby's heart rate is otherwise flat, and you look at the scan and there's low fluid or the baby's not moving much, that's much more worrisome.
Mhm.
Um, the problem with these tests, and it's been shown over the entire years of usage, over 50 years of use, and I think it's Hannah Dahlen in Australia who does a lot of talk on this. I might have the wrong name, but luckily got to hear this person speak about continuous fetal monitoring. They call it CTG monitoring.
Mhm.
That it has not shown any benefit, not in antepartum testing, not in labor, not in screening a woman who comes into labor for putting her on the monitor for half an hour before they let her
Mhm.
go walking.
Yeah.
None of that has shown any benefit. The only area where it's shown a little bit of benefit is potentially a woman in labor with a truly growth restricted baby.
Okay.
So to do, and that's what the data shows. So
Right.
to do a non-stress test, um, or to put a woman on a monitor in the hospital when she comes in before you'll let her go walking, there's no data for that. They just
Right.
do it again. Silly me, but they can bill for that.
Yeah.
They don't do it, they can't bill for that.
Yeah.
And they also figure that they covers their liability. If there is something wrong and they let her go walking, they're going to get sued. The problem is she's been walking for 9 months without your supervision and she's been fine.
Mhm.
Since she comes to the hospital and now she's, a ticking time bomb, that's how they look at you. But it doesn't make sense.
And the
And
moral of this
we've
go
go ahead.
ahead.
No, we've created a world where women are fearful of birth because they've been indoctrinated to believe that something could go wrong at any moment. And that's the story that's being told and propagated, and it benefits the system. It's mostly not true. We are going to be wrong sometimes. We're going to miss something, and some babies will suffer for it. But all you have to do is look at the outcomes that the system has generated now, and babies are suffering for it constantly at a much higher rate than they were 50 years ago.
And I'll say just from, experience as a mother myself, my first 3 pregnancies in a hospital-based system, they did not bring NST up once. They did not bring up having a non-stress test. They did not do it blanket statement. It was based on need. Now, my 4th pregnancy, when I started in a different hospital-based system initially, that is where it was standard of care for them to do it for all women past their due date. That's when I ended up leaving and seeking out a home birth midwife. So just for those listening to know, just because your provider is doing it and saying like, oh, all women get it when you go past your due date, that doesn't mean that's even what all hospital-based systems are doing. That's just specific to where you're at. And so the big goal of today's conversation with Dr. Stu is to teach you that you have options. And just because the practice you're doing it at is doing it a certain way doesn't mean that that is the right way, nor does it mean that you don't still have options to be able to speak up for yourself if your gut is telling you that it doesn't feel right for you.
I would also add, if you'll let me, that there are
Yeah.
2 terms that are often thrown out by physicians to support what they're doing: evidence-based and standard of care. And I have a strong dislike for those terms because they don't mean what you think they mean. Evidence-based means that there's some evidence that may support what they're doing, but what the quality of that evidence is, you don't know. And it doesn't mean there isn't evidence that the opposite is true. So evidence-based medicine is a term that doesn't really mean anything. It's an authoritative term. It sounds like it means that there's good science behind it. Doesn't necessarily mean that at all. So if some doctor says, well, we're following ACOG guidelines and evidence-based guidelines, you need to ask them, well, how good is their evidence? What evidence are you using? They're not going to like it when you do that because they don't have the time to do that with you, but you deserve that explanation. Because 67% of 2/3 of ACOG guidelines are what are called level C evidence. Level C evidence is basically poor science or consensus opinion. Level A evidence is like a randomized double-blinded controlled trial. It's the cream of the crop. And level B evidence is like meta-analysis or record review or that sort of thing. But 2/3 of the recommendations ACOG puts out are based on consensus opinion. And what kind of opinion do you think you're going to get from ACOG's guideline committee, which is made up mainly of maternal fetal medicine specialists who are high-risk specialists who see every pregnancy as a potential disaster? That's what they do. ACOG even has a statement that says pregnancy itself is a high-risk condition. Now, if that's the way the prism that ACOG sees pregnancy through, then you can understand why every woman is high risk. There was a meme that came across my Instagram feed of Marcin Wagner. Some of you may know who he is. He's passed away. He was in the several interviews in The Business of Being Born. He's a very wise man, and I never met him. He was a mentor to me. And he said many things about hospital birth versus home birth, but one of the things that he says is that for low-risk women, home birth is better. So what's interesting about that is if I was ACOG, I would say, well, the evidence-based says that's true.
Right.
But no, what does ACOG do? They're trying to find ways to label all pregnant women high risk. So there are no low-risk women. So therefore, nobody could have a home birth. I mean, it's absurd what they do. And the other term is called standard of care. Standard of care, it's got a poor definition. It's weak. It's basically what the average prudent physician in your community would do. So if you live in a community where nobody offers VBAC, then the standard of care is to not offer VBAC. And if you live in a community where nobody offers breech delivery, then the standard of care is to section all breaches. But is that a good standard of care? And the answer is no. It's a sucky standard of care.
Mm-hmm.
But yet they'll throw the term out there as if it's authoritative, as if it means something. And so are they doing this on purpose? Some doctors, I think, are doing it on purpose. Other doctors truly believe it because it's sort of a mass formation thing where to realize that I've been doing something unnecessary to women for 20 years is something that's very hard for any doctor to face. Every doctor has done unnecessary C-sections. There isn't one that hasn't.
Mm-hmm.
Yet you ask any doctor if he's ever done unnecessary C-section, then they'll say, of course not. But we can't believe that 35% of all women having C-sections means that they're all necessary. It's not possible, right? And in some countries, we're talking 60, 70, 80% C-section rates with no concern about that's doing downstream to our species. None whatsoever. Because that's not where the values are placed in that system.
Right.
Values are placed in that system of generating revenue and limiting liability.
Mm-hmm.
And I listen, if I was running a hospital, that would be my two priorities too.
Sure.
It wouldn't be to cater to Mrs. Smith's weird birth plan.
Yeah.
It
Right. They're
wouldn't.
looking at the bottom line.
Yes, of course they are,
So,
and that's not wrong for them. That's why we individuals have to fight for what's one, and we have to reteach our young women that birth is normal, that pregnancy is a normal function of your body. Occasionally goes awry, like breathing or like digestion. It can occasionally go awry, but most of the time it doesn't. And when it does, that's when you need medical help, and that's when doctors and maternal fetal medicine specialists are very valuable.
absolutely.
But that may be 10 or 15% of pregnant women,
Right.
not 98%.
I think that's a great point to close today's conversation on is, what does true informed consent in birth actually look like, especially for a mother who wants to allow her body to move through physiological birth? What would you leave our audience with today?
Well, informed consent is another thing that's often mistaken for what it means. Doctors don't give you informed consent. Just people understand that. Doctors give you information, you give consent. And the truth is, you have the right to get all the information before you can give good informed give consent. And if you're only given skewed information or selective information, then your consent really isn't informed. It's uninformed consent, which is not really consent at all. It's basically a form of coercion when they only tell you the downsides of, say, VBAC versus the positivity, and they don't ask you, by the way, do you want a third baby? Do you want a fourth baby? Because if I do a repeat C-section on you for your second baby, I've just put your third baby and your fourth baby at much greater risk than if you have a VBAC with your second baby. And ideally, you wanted to avoid that first C-section, which is the problem because most women for their first baby are scared, so they end up choosing the hospital because they say, oh, I'll have this one in the hospital and then I'll have future ones at home. But then the hospital turns into the cascade of interventions and they end up with a traumatic experience. So true informed consent is probably not really possible, Kayla, because of time constraints and the limits of our knowledge. We can't give it. I mean, I use an example of, when I teach my course, I ask the midwives, do you guys use lidocaine? And everybody goes, yeah, of course. We're not going to stitch somebody up without lidocaine. And I go, well, do you give true informed consent on lidocaine? And then some women, they say yes. And I say, okay, well, do you tell them they could die? And they go, well, no. But if you read the package insert, it is a known risk of giving lidocaine, 1 in a million. It's a ridiculously low number, and it's not worth mentioning. But so
Sure.
true informed consent is not something that we can give. What's too often given is skewed informed consent, is giving women information to funnel them down the path you want them to take. And that's what normally goes on in the doctor's office or the hospital, where they hand you a consent form and you're in labor and they hand you a consent form, they want you to sign it. Don't sign it. Okay. The consent form is there to protect the hospital. It's not there to protect you. And there are things in the consent form that you may not understand that may lead to things being done to you or your baby that you didn't give permission for, but you actually in language you did. So you don't have to sign a consent form when you go to the hospital. I'm not trying to cause trouble when you go to the hospital, but you don't have to sign a financial agreement, consent form, any of their forms when you go to the hospital, because by law, they have to take care of you no matter what.
Hmm.
There's something called the EMTALA law, which is Emergency Medical Treatment and Labor Act or something like that. And they cannot refuse care to anyone who's in labor. And so don't sign under duress. Because if you're coming in for an induction, you have time to sit there and read the whole thing, that's fine. But if you're coming in labor and they want you to sign forms so they can get you a wristband so they can get you admitted, that's not a reason to be signing consent forms, because it's not informed consent. Honest informed consent is what we should try to do, and that requires time. And that's why the midwifery model of care, I think, is so much better, because your prenatal visits are generally an hour long for the most part. Maybe some are shorter, but they're certainly longer than OB-GYN visits. So you have more time to talk about these things, and you can get into depth about group B strep, or about diabetes screening, or about herpes. And you can talk about the pros and cons of doing this, that, and the other thing, as opposed to just kind of spewing out language that's a little bit coercive to get the woman to have the beta strep swab, or get the DTaP vaccine at 28 weeks, or whatever. You just, they don't have the time to talk to you about these things, and you don't have the time to question. And that should be a red flag for any pregnant family. If you go there and the doctor's got one foot in the door and not looking at you as they're typing into their EMR, or you only have 6 or 7 minutes, or you leave the office feeling more nervous than when you came in, listen to your body, listen to your intuition. That's a red flag. That's maybe something you should look elsewhere for other options, even if you have to go out of pocket to do it. Because again, the experience of how you give birth is going to be with you your entire life. Yes, I'm a male and I'm saying that, but you know what? I can empathize. I have dealt with families over 40 years, my entire career. Every day I'm responding to even though I'm retired technically from birthing, I'm responding to women online every day, hearing their stories, and they're not getting better, by the way. I mean, I love when people send me these lovely redemptive stories of these great births that they have, but those letters are fewer and far between the ones where there's a question like, is what my doctor telling me honest? Now, the fact that she has to ask me that question is very tragic. So that's the whole thing about consent, is that it cannot be given under duress. There are certain ethical guidelines that say how doctors are supposed to consent you. And if your doctor follows ACOG guidelines, then you should take out committee opinion number 664. You could look it up yourself. It is ACOG's guidelines on informed consent and ethics. And it is fascinating. It's jaw-dropping when you read it, because all the stories you hear about what's done to women at the hospital are in violation of their ACOG's own guideline. So if you know these things before you go in, you can prevent them from happening. And ideally, you don't want the adversarial situation to occur at that moment. You want to plan this out all ahead of time. Check out your hospital system long before you're pregnant. Go up to labor and delivery one day and just ask if you can speak to the charge nurse and ask some questions about it. What do you do if you go past 41 weeks here? What do the doctors do if I break my bag of waters at term and I'm not contracting? These sorts of things. What do they do if I decline antibiotics for group B strep? What will the nursery do? Will they take my baby? Well, these kind of questions are things that the average pregnant woman doesn't think of until they're forced upon them at a time when there's drama going on, and you don't, you're put in a box of like, well, if you don't do this, your baby might die kind of scenario. You need to know that way ahead of time, because that, by the way, is used way too frequently too.
Well, Dr. Stu, thank you so much for joining us today and sharing your perspective and experience with such honesty and nuance. And personally, I just want to say thank you. During my own pregnancy with my fourth baby, I learned so much from listening to the Birthing Instincts podcast, while prayerfully discerning whether I should do a home birth or a hospital-based delivery, and ultimately chose a home birth and had a beautiful, positive experience, which is exactly what I was seeking. So I truly appreciate the way that you approach these conversations with both clinical experience and just a huge background of knowledge, and not being afraid to speak the truth that is on your mind, because a lot, as you got into today, there's just a lot of red flags out there and a lot that has to be filtered when somebody is speaking for an organization, and you're able to just speak on your own behalf and from your own experience and evidence in that regard. So I appreciate it.
You're welcome. And Somebody taught me a long time ago the best way to learn things is repetition and storytelling. So that's, I think that that's true. And even though I come on podcasts and I go with Bliss every week on a podcast, and sometimes I feel like a broken record,
Sure.
I know that each time I speak this out, it gets echoed and it gets passed on to somebody else, and somebody will be curious and somebody will change the course of their pregnancy because they heard it, and they will start to do their own investigation. And then they may end up with a redemptive home birth, and their other kids were around to see it. And that generation will then change the next generation because they're not going to be as fearful of birth because, hey, mom did it in the living room.
Yeah.
I saw little
Literally.
brother Billy. I saw brother Billy's little butt come out first, and it was really cute. And I remember how, calm everybody was in the room. And that will imprint upon those children who then grow up, and they'll know when they're being gaslit, and they'll know when what choices that they are possible for them. So again, I know sometimes I go off on tangents and I feel like, does everybody want to keep hearing this? But the ultimate truth is that, yeah, you need to keep hearing it because the other side isn't going to stop telling you that birth is dangerous. They're not going to stop.
Dr. Stu, before we wrap up, where can listeners continue learning from you and follow your work?
Thanks, Kayla. My website is everything is Birthing Instinct. So it's birthinginstincts.com is my website. The podcast with Bliss Young is Birthing Instincts Podcast. Um, I teach seminars around the world on breech and twin skills. And between me and a lovely organization called Breech Without Borders, we're probably the only two organizations that are actually still trying to keep this skill going. So that's very important for me. Um, I yeah, I'm working on some projects. Do that, and then on Instagram, of course, it's Birthing Instincts too, also. So that's where they can find me. I tend to respond to every DM I get. It's getting harder
I'm
because
sure.
I getting more every day. But I do have a fairly nice lifestyle right now where I'm home in my homestead this summer. I'm taking some time off to enjoy my homestead rather than spending traveling all the time. So I do respond to questions from people. I actually do offer virtual meetings or consults for people that want to have a more in-depth conversation with me, and there's different pricing on that. That's all on the website. Yeah, I think that's probably it. So it's Birthing Instincts was a random choice I made of a name long ago, and it turns out to be a really good choice.
Amazing. It stuck well. Well, thank you so much, Dr. Stu, and thank you for tuning in. As always, take care and be well.
Thanks, Dr. Kayla. I really appreciate you having me on.
Absolutely.